Thank you for joining me for this IRB proposal today. I've titled this proposal Impact of Incremental Saturated Fat on Metabolic Parameters in Low Carbohydrate, High Fat Diets for the Management of Obesity and Glycemic Control in Diabetes mellitus Type 2. Why study saturated fat? Saturated fat is ubiquitous in the American diet. We encounter it in animal fats, butter, cheese, coconut oil, certain types of cooking oils, and also in processed foods. Each of these categories often sparks controversy unto itself. People will debate whether or not they should be having Kerrygold butter or coconut oil in their bulletproof coffee, whether or not they should be eating reduced or full-fat cheeses, same thing for milk, and then also they'll be looking at the types of animal fats that they're taking in. In reality, looking at saturated fat, we can really reduce it to four basic types that we're going to be interested in. This is going to be lauric acid, myristic acid, palmitic acid, and stearic acid. And these are your 12, 14, 16, and 18 saturated fatty acid carbon chains. When we look at saturated fat research, it's very broad. It covers many different dimensions of interest. However, it often lacks specificity, and this is the reason why I've chosen this pilot study. I've picked a specific setting: low carbohydrate, high fat diets, and diabetes mellitus type 2. Why? Well, low carbohydrate, high fat diets have become very popular in diabetes mellitus type 2 to manage both glycemic control and also obesity. Now, the diabetes mellitus type 2 is characterized by difficulty in controlling blood glucose, but it really is a systemic endocrine disorder. It's characterized by two facets. It has insulin resistance that's occurring in the musculoskeletal system and a reduction of insulin production in the beta cells of the pancreas. This means that the disease is heterogeneous, and when we look at it as clinical management, it means that we're going to have to individualize the therapy to the patient. That individualization can be looked at as four boxes: psychosocial wellness, exercise, nutrition, and medication. When we look at the diabetic guidelines to help get insight into what part of nutrition we want to address with a specific diet, we find that the American Diabetes Association and the American Association of Clinical Endocrinologists, who have produced these guidelines, do not give us a specific ideal diet for diabetic management. What we find instead is that there is specific instruction for certain types of dietary patterns and key things to avoid. That might be something like trans fat. It might be taking in low glycemic index carbohydrate sources. But in general, there will be a support for general nutritional education, for medical nutritional therapy and specific interventions, but all in the absence of a specific type of diet. Now, one part just relates to the need to individualize to patients and providing a big tent that everybody can work under. The second part of it really speaks, though, to a lack of evidence in our understanding of what is a best diet for a diabetic patient. When we look at some of the recent research that's been done in these type of diets, we find that typically glycemic index diets that focus on low glycemic index foods, Mediterranean diets, and low carbohydrate, high fat diets have similar outcomes in the reduction of obesity, and all of them have an advantage in providing reduction of anti-diabetic medications. In some cases, a low carbohydrate, high fat diet may end up blending some of the elements of low glycemic foods and also the Mediterranean diet by virtue of the type of fat sources that are being selected. When we look at these type of diets, what we'll find is that the carbohydrate source, if it's being designed well, will frequently be targeted towards providing the most type of fiber and the least amount of refined carbohydrates that can be added into the diet. The high fat source, if it's designed well, will focus on what are considered healthy fats and probably minimize the amount of saturated fat that is there. What we're very interested, though, is in understanding what the impact is of adding more saturated fat into such type of a diet. I'd now like to switch gears a little bit and talk about the study design itself. This proposal is going to be a pilot study for 3 months, and the design is a 3-arm randomized block group design that limits the amount of variability in between groups. The basic diet that all members of the study will have will be a whole foods type diet that reduces the amount of processed food being taken in. Carbohydrates would be limited to 50 to 80 grams of unrefined carbohydrate source. The protein would be limited to 1.2 grams per kilogram. There would be a 10% decrease in the amount of calories taken in, and the remainder of macronutrient between the carbohydrate and protein to be taken in will be fat, and the fats will be divided into a 5% saturated fat, 10% saturated fat, and 20% saturated fat. These different categories are reflecting the American Heart Association recommendation for reducing saturated fat to about under 6% based on if you have cardiovascular issues. The 10% group will represent the Dietary Guideline Action Committee's recommendation to reduce saturated fat roughly below 10%. And the 20% group is looking at people who are not adhering to that, but still following the lower carbohydrate, high fat diet. The primary outcome in this study is the development of a linear regression model to see if there is a relationship in incremental saturated fat increase and lipid parameters. The lipid parameters we're selecting are apolipoprotein A1, B, triglycerides, HDL cholesterol, LDL cholesterol, and total cholesterol. The 5 parameters used in the linear regression model will be changes in BMI, age, and then statin use, low, medium, or high. The secondary outcomes of this study would be described by simple statistics. We will be looking at changes in hemoglobin A1C, changes in BMI, changes in the amount of fasting blood glucose as far as the relative distance between low and high readings. We'll also be doing a satiety and robustness survey to determine whether or not this is a diet that could last for a long time. The benefits and risks. The benefits to the participants are many. One, they're going to get a significant amount of dietary education in the study based on the study design. They're also going to get a significant amount of support for their diabetes care, and they're going to get the opportunity to be educated on their diabetes care. There's a high likelihood that they may adopt a lowered amount of anti-diabetic medication on these diets, which may be something they choose to stay with, and their exposure to these different diet types gives them the opportunity to focus on healthier foods coming from whole food sources. There are risks. The risks are limited in the sense that when we look at saturated fat being increased, we're looking mostly at major adverse cardiac events and in relation to increases in LDL. The risks are limited because the study is only 3 months, and of 2 of the groups, one is eating the heart healthiest diet in regard to saturated fat of about 5%, and the second one is meeting general recommendation guidelines from the Dietary Guideline Action Committee, which is roughly about 10%. The third group does have a risk there. Because we're taking baseline measurements and we're also following these patients carefully, believe the risk will be minimal to them. What can be learned from this study? And why is this study significant to do? The key importance of doing this type of study is the ability to understand what a specific intervention does in a specific disease state using a specific diet. When clinicians have this sort of information, they're able to make more informed therapeutic decisions with their patients in our shared decision model because they can better estimate what the effect will be. It's true that individuals are going to be different. One person may state, I already eat a diet that is rich in saturated fat and my lipids look fine, while another person might state, I've tried something like that and my lipids turned bad. When we understand the linear increase, we can make a better judgment. This is more specific information. This is answering the question of, hey, I'd like to add 2 ounces of non-reduced fat cheese to my diet. What do you think that will do? Oh, well, let me tell you. Being able to interact with our patients in that manner helps us to be more precise in their care. I want to thank you for joining me today for this IRB proposal. I'll refer you to the IRB proposal itself for the many specifics that are found inside of it. Thank you again.